Hello, and thank you for checking out FirstcallID, approach to how to do an infectious diseases consultation. My name is Bunce, and I'm an ID physician. We'll be spending the next 15 or so minutes going over some of the key aspects of an infectious diseases consultation. This should build upon your basic approach to taking a patient history and performing and documenting a physical examination. And lastly, before we move forward, just a quick note that this information is for educational purposes only. Please refer to clinical guidelines and use your professional judgment in practice. But before we get into the details, I just wanted to give a few words, especially to those who are relatively early in their exposure and experience in infectious diseases. There are some common challenges that many people face, especially early on in their training. And these relate to, well, one, how much detail and depth do you really need to go into? Sometimes there's a sense that you need to know about everything the patient's ever done, and sometimes it's not always relevant. So really getting a sense of what's required. How far back do you have to dig? Do you have to look back at their microbiology from childhood, or can you focus on just the current admission? And really one of the big challenges, which I have no way to really define, is what does your attending want to know? And every attending is a little bit different with what their expectations are, but there are some key things that most people who practice an ID would really want to be covered. So the key points to an infectious diseases consultation. First is the pre-consult logistics. Really articulating and clarifying the question being asked of you and determining what the expectations are from the referring service. When we're gathering our history, we do pay attention to the identifying data, the sort of basics of the patient's story, timeline of their symptoms and events, relevant surgical history, exposure history, antibiotic exposures and response to therapy, comorbidities and medications, especially those that affect the immune system, and a careful allergy history focusing on antimicrobial allergies and their side effects or their effects. When we talk about the ID physical examination, we always comment on the stability of the patient. We document and catalog the lines, tubes, and drains. We always assess for stigmata of infective endocarditis. And in addition to our observations, we usually want to palpate as well. With the investigations, we always document the CBC. We'll note any renal dysfunction, often assess for markers of inflammation. As you'd expect, we really do focus on the microbiology, and we look at the imaging with our own eyes. And from all of this information, we provide our summary and impression and our recommendations. So a bit of detail into the pre-consult logistics. So when you are getting the consult, if you're getting it directly, really clarify what's being asked. Is this a diagnostic question? Are they asking you for assistance with management? Or is there some other reason that ID is being involved? And sometimes it's simply for something like clearance prior to the implantation of a pacemaker. Sometimes the referring team just wants us to provide support for their recommendations or to provide some reassurance that what they're recommending is sound and something that the patient can feel comfortable with. We'll always want to clarify what are the disposition plans for the patient if it's known. Are they going to go home today? Are they going to go home in a week? Do we have time to work on things and figure it out? Also, are they going to be going home or to another medical facility where it sometimes is easier to administer IV antibiotics, for example? The other thing I'll often ask, especially if I'm practicing by myself without training, is can we enter orders directly? Can we enter antibiotic changes or any investigations, or should we make them as suggest orders? And something that some teams are really happy for us to do, but you want to clarify that at the outset. In terms of the history gathering, again, identifying data. What is their living situation? What is their relationship status? Occupation if they're working outside of the home, country of birth, and when did they immigrate to wherever you're working? And asking about hobbies, sometimes peripherally, sometimes it's relevant, sometimes it's a conversation starter. We get a clear timeline of the key events, the response to any therapies, and we'll always include a final note about constitutional symptoms. Often patients aren't going to know that constitutional symptoms are significant. That's why we sometimes have to ask it explicitly. We'll ask about a relevant surgical history, exposure history, do you have any pets, do you have any cats, and habits. We'll ask about their antibiotic history, comorbidities and medications, especially those that affect the immune system, anticoagulants in terms of interactions for significant medications, and as I mentioned, a careful allergy history, especially with antimicrobials, and the reactions that they've had if they can recall it. The quote ID physical examination includes patient stability or instability, the most illustrative vitals, so Tmax. We don't need to know the sort of chronology of every temperature over the past 24 hours. If they've had a fever within the past 24 hours, that's usually all we need to make note of. And we want to note if there's any change in their vitals with any therapies that have been enacted. We'll catalog the lines, tubes, and drains and when they were inserted. We'll assess for stigmata of infective endocarditis. And when we're examining the patient, we'll always look in the mouth, always examine for lymphadenopathy, and always examine wounds with your own eyes. If you're able to, taking a photograph that can be put into the chart, that's also really helpful. And as I said before, don't just look, palpate. You have to sometimes feel, especially for soft tissue inflammatory processes, feel for any abscess or fluctuance. In terms of investigations, we'll always look at the CBC, really paying attention to the differential of the white blood cell count. We'll look at the other routine lab values as well. We'll pay attention to renal dysfunction just because we'll have to adjust our antimicrobials sometimes. We'll assess for markers of inflammation. We'll carefully review the microbiology. And when it comes to medical imaging, I think it's crucial that we look with our own eyes at the images. Sometimes it makes a world of difference to see with your own eyes what the radiologists are referring to. It gives us a much better sense of what's going on. And from all of this information, we'll summarize the case as succinctly as possible, and we will define the syndrome as best we can. We'll consider any immunosuppression or immunocompromising factors or things that would change our suspected pathogens in a particular patient. And then we'll also identify the potential need and urgency for any source control measures. When it comes to our recommendations, really focus on the question that's being asked of us. And use caution when commenting on aspects that are outside of the referral question or for non-ID related issues. Be concrete and explicit. Don't leave your recommendations open to interpretation. Be concrete. Consider, in some cases, giving the referring service some options. You can use this or this in terms of your management. Versus a single concrete, this is what we recommend. And it really is case by case what the preferred strategy is for that. It's important to advocate for interventions when they're needed, such as source control, surgical intervention, a diagnostic procedure, but avoid absolute demands because you start to risk losing your credibility if you say, this person must have surgery, this person must have this done, and it doesn't happen, the person does fine. So really saving your strong advocacy for those really critical moments where it matters. And the last thing is really try to be helpful, right? We provide a service and we want people to want us to come back and support the care of their patients. So be helpful as we can. So just to recap, when we're performing an ID consultation, when we're getting the consultation, we'll just make sure we clarify the question and determine the expectations being asked of us. We'll provide a comprehensive medical history focusing on the ID-related issues. Our ID-related physical examination will pay specific attention to the patient's stability, their fever pattern, lines, tubes, and drains, always looking for stigmata of endocarditis. And when we look at investigations, we look at the complete blood count and note the regular blood work as well. We'll assess for markers of inflammation when relevant, careful attention to the microbiology, and always looking at the imaging with our own eyes. And from this, we'll provide our summary, our impression, and our recommendations. And just a few words or thoughts for those who are early in their ID exposure. I'll just say that when you are doing this for the first few times, it can be really tough. And it sometimes feels that no matter what you write down in terms of your suggestions, your attending, your fellow will disagree with you or tell you that you're wrong. And it's not you. There's just often more than one way to do things. And I think early on, it's really important to be patient, to listen to the feedback you're getting, to read, to learn from every case, read some more, and supplement your learning. And I will also say that although it can be really challenging along the way, when mastered, or if it can be mastered, ID is one of the most cognitively stimulating and rewarding specialties in all of medicine. So certainly worth the effort. And so for some additional resources, The Art and Science of the Infectious Diseases Consultation is a helpful review article. And if you're looking for something a little bit more in depth, the Infectious Diseases Consult Handbook is also available online. So that's all for now. I'm Paul Bunce, and I want to thank you again for watching, and please share any feedback you have with us about the session or about FirstcallID as a whole. And if this is helpful to you, feel free to tell a friend. Take care.